reviewing the scientific literature to answer your questions about gender diversity. This is Classroom Psychology. And now here's your host, Dr. Cora Sargent. Hello everybody and welcome to Classroom Psychology. I'm your host Cora. Thank you so very much for joining me. You got three verys today. It is wonderful to see you. Hop on in here. It's wonderful that you're here. Let's talk about gender diversity. And this week, much like we do every time we come together, we take a public statement from a politician or a book author or, some commentator who just likes talking about this topic, and we take their often confidently declared statements for the questions we're sure they're intended to be, and we see if we can't work together to look at the scientific literature to find an answer. And this week, our question comes from Dr. Frank Turek, who is an American author, public speaker, radio host, award-winning author, and co-author of 4 books, I believe. So here is Dr. Frank Turek.
And by the way, 80% of young people that have this so-called gender dysphoria, whether it's social media driven or not, grow out of it by the time they're 18. So it really makes no sense to give them cross-sex hormones or surgery, permanent solutions to a temporary problem.
Thanks to Dr. Turek for such an interesting question, posed as they often are in the form of confident declaration. But this week we also have a question from a listener. A very special question, very special listener. Every so often we do get questions from listeners. Wonderful to hear from you. Please don't hesitate to get in touch. You can find me on X at Classroom Psych. You can always DM me. Or you can find me at the University of Southampton. You can find my email address is public there. And don't hesitate to email. If you have a question or you have comments or would. And also, if you want to leave a rating, give us a rating, leave us a comment. We do read them. And you'll also find us on Classroom Psychology on our YouTube series. You can find us there. We do a little bit of a YouTube series, and obviously the podcast is on YouTube there as well. So you can always leave a comment there as well. We do read them, do respond to them. They are important. But we have had a very interesting question from a young person in Germany. Will not reveal their name or will not reveal their anything about what they write, with the exception that they describe a German study that was published this year. Now, this study is one that I have already come across and is it's a super interesting piece of work that's been done in Germany about the extent to which people who transition as young people in Germany who engage in transition-related healthcare, public healthcare, continue to engage in that healthcare like 5 years later. And it found what it describes as a low, in inverted commas, persistence rate. Now, we've talked about desistance and persistence in the past, and it's really interesting that they use that language, but it's a really interesting study. And this young person's email basically said that their family was using that study to invite them to detransition. And that is obviously a pretty heart-rending story, to be honest. My heart absolutely goes out to them, and they are absolutely not alone. And what they've asked for us to do is to critique this study, basically. And interestingly, 2 days ago, another study was published out of the States, which aims to answer the same research question using extremely different methods. So let's do a deep dive in answer to this question from Frank Turek and in answer to this question from our young listener. The question really is, what is all of this? These 2 studies find remarkably different things, remarkably different, in inverted commas, persistence rates for young people who transition. How do we understand the persistence rates of young people transitioning? And how do we rationalize these 2 very, very distinctly different studies, one out of Germany, one out of the US, finding remarkably different things? How do we understand persistence and desistance rates? Terrible language, I know. How do we understand young people's gender identities and whether or not they stay static or change over time and in what circumstances. How do we rationalize these two studies? So that is going to be the focus of today's episode. We're going to do a deep dive into both studies, and we're going to see if we can't find an answer to this question. So let's take a look. So the first of these studies comes from the Deutsche Arztblatt International in 2024. It was published this year, just earlier this year, by Bachmann, Golub, and Holstige and Hoffman, called Gender Identity Disorders Among Young People in Germany, Prevalence and Trends, 2013 to 2022, an analysis of nationwide routine insurance data. So whenever we do a deep dive, we haven't done a deep dive. I don't know if we've ever done a deep dive. We ever done a deep dive into an article? We're going to take a look at a bunch of different things. We're going to take a look at the authors. No judgment of the authors. Like, we're just looking at their academic credentials and just having a look at, see who they are. We're going to look at the journal. We're going to look at an overview of the concepts being discussed. Then we're going to look at the background and rationale. We're going to look at the aim and design. We're going to look at the results. We're going to look at the discussion. And then we're going to do a bit of critique and see if we can't understand how these two articles found such different results. So the authors of this one, Christian Bachmann is the lead author. He's associate professor at Ulm University Medical Center in Germany. He is specifically in the Department for Child and Adolescent Psychiatry. He holds a director role at the Catholic Children's Hospital in Wilhelmsstift in Hamburg. He's getting a sort of specialism by the looks of things in gender identity, though I don't think that's been his primary focus historically. He's an extremely prolific author, 82 or so publications, which dwarfs my own publication history considerably. Golub and Holstige and Hoffman, all co-authors, all like focused on things like public healthcare and epidemiology, particularly around mental health services and particularly on healthcare trends through insurance data. The group as a whole have published around adolescent mental health, but I don't think they've done a huge amount of work in gender identity before this. Still, an impressive group of researchers with Bachmann at the helm. 82 or so publications is nothing to sniff at. I've got 15, I think, maybe 14. Certainly nothing like 82. Well done, Christian Bachmann. Now, the journal is Deutsche Arztblatt International, which is the German Medical Journal International. It's a weekly peer-reviewed open access journal. It covers mostly clinical medicine and public health. It's also the official international bilingual science journal of the German Medical Association. Now, here's where things get, I think, super interesting. The current impact factor over 2 years is 6.5, 5 years, 7.4, but somewhere between 6 and 8, right? So that impact factor means that articles, 2-year impact factor means that articles were published in the journal over those 2 years were cited in 6.5 other studies. Now, in terms of gender identity, it's really rare to publish in really high impact journals generally. And here, 6.5 is pretty high for journals that I would publish in, at least anyway. And hey, I'm not a leading international scientist in this field, for sure. But 6.5 is nothing to sniff at. It's a beefy journal. It's a beefy journal, right? Considering the kind of places where I've published before, at least to me, it's pretty beefy. Publishing this 6.5 impact factor journal, that's pretty beefy. Now, conceptually, it's really interesting, this article. Do take a look. It is open access. Do take a look. It is an interesting piece of work. And it is interesting how they refer to gender diversity in the piece. They talk about gender identity disorders, and they talk about the stability of these diagnoses over time and psychiatric comorbidities. So now the authors use an interesting phrase to describe disorders of gender identity. They use Störungen. Give me a sec. Hey, I'm looking for some help pronouncing a German phrase. Störungen der Geschlechtsidentität. That's pretty bad, right?
You're almost there. In German, Störungen der Geschlechtsidentität is pronounced like this. Störungen der Geschlechtsidentität.
Störungen der Geschlechtsidentität. I don't think that was any better. But it translates to disorders of gender identity. Now, this is not a term that's used by the community, which uses transgender, or less commonly transgeschlechtlich, or Geschlechtsikongruenz, which is gender incongruence. So it's not a phrase that is used by the community itself, and that I think gives away a little bit that there are not necessarily any kind of gender diverse people on the research panel. There often aren't, by the way, but it can. And if you're not super hooked into the community, then you can use language that's either outdated or overly medicalized, and it can be a bit difficult to, it sort of reveals something about the authors, I suppose. Now, conceptually, we're talking about trans folk, we're talking about gender identity, you're talking about gender expression, and it's important that we understand that there is a difference between gender identity and gender expression, right? Gender expression is how we perform our gender to ourselves and to the world. Gender identity is that's right, that feels like home, that's what I am. Gender identity can be fixed or more stable. It might be one place or multiple, and it can change over time. Gender expression, on the other hand, we have more conscious control over, right? We can choose how to express ourselves in the world in accordance with or against gender norms. The other thing that's important for us to bear in mind here is that transgender folk are not always binary transgender, right? Trans folk include, if we use the very broad umbrella of trans folk, it includes gender diverse folk that are not binary, not including non-binary communities, but also gender diverse communities that find themselves somewhere in the gender spectrum that aren't strictly like femme or masc, like in strict kind of binary terms, right? So that's important. Those two things, we need to bear in mind that gender identity and gender expression are different to one another. And we need to bear in mind that trans folk include non-binary communities in our understanding of this, right? And these authors don't necessarily include all of those understandings in their write-up, because the way in which they define trans folk to be included in the study is pretty unusual. We'll get into it. Now, the point about gender diversity and non-binary communities is really important here, because Herman and colleagues in 2023, Binary and Non-Binary Gender Identities, Internalizing Problems and Treatment Wishes Among Adolescents Referred to a Gender Identity Clinic in Germany, found that about 10% of the trans population considered themselves to be non-binary, right? So that's really important. Also, that's replicated in some other research I've been seeing in the States that identifies about 10% of the trans population is non-binary, which is really important. So, if we exclude non-binary folk from thinking about trans folk, then we're excluding like 10% of the trans population. Important. So the aim of this research was to take a look, without looking at self-report, was to take a look at the trends in prevalence of gender identity disorders, in inverted commas, the stability of these diagnoses over time, and any psychiatric comorbidities, whether they also experienced other like mental health challenges, essentially. Now here's where it gets really interesting. Now the authors looked at the nationwide billing data of the statutory health insurance physicians in Germany. So as I understand it, I had to do a bunch of reading to try and understand what was going on here. But as I understand it, in Germany, in order for people to essentially recoup their costs, to charge the government and the health system for medical services they provide under the National Health Insurance Program, they have to diagnose somebody and then sort of bill the National Insurance Physicians in Germany, the Statutory Health Insurance Physicians in Germany program. They bill them using those diagnoses. So they essentially diagnose somebody with somebody, they provide like medical services, and then they bill the National Insurance Program to recoup their costs, right, for the medical services that they provide. Now, that's important. And when it comes to mental health, they're talking about the ICD-10, which is the International Classification of Disorders 10, which is a common manual of disorders that is used in a lot of Europe, essentially. It's sort of against the US Diagnostic and Statistical Manual, the DSM. The ICD-10 is the European version. The ICD-10 has been replaced with an ICD-11. An ICD-11 sort of has a more modern understanding of gender diversity in it. The ICD-10 diagnoses, though, are a little bit older, a little bit unusual, and they're the ones that they had to use because while the ICD-10 has been adopted by Germany, it is the ICD-11, the new updated version, has been updated and used in Germany. It is not actually actively being used in the health system quite yet. It's on its way, but currently still the ICD-10, it's, you can understand why, because the whole national insurance system for medical services is bound up in the ICD-10 diagnostic classification system, and to switch over to a whole new system creates some like logistical nightmares that the government has to try to solve before it can put them in place. So while it has adopted it, it hasn't yet found its way into the healthcare system, necessarily into the billing system. And so our researchers here are still using the ICD-10 diagnoses in the billing system to identify people who are transgender. And that's problematic because they have only in the ICD-10 the F64 spectrum of diagnoses to go on. F64 basically is any gender identity disorder. Now, we've talked a little bit about how these older studies can use terms, like diagnostic classifications like gender identity disorder, but they don't really reflect in their nuance how we would think about gender diversity in modern terms, right? And here's a good example. So they use F64. F64.0 is transsexualism. That's kind of what we would consider as like binary transgender. It's essentially a desire to live and be accepted as a member of the opposite sex, usually accompanied by a sense of discomfort with or inappropriateness of one's own anatomic sex, and a wish to have surgery and hormonal treatment to make one's body as congruent as possible with one's preferred sex. So it's not far away. I mean, it doesn't describe gender dysphoria or gender euphoria, which are kind of hallmarks of the modern trans experience. Certainly gender euphoria, gender dysphoria are kind of inevitable consequence of the binarization of society and gender essentialist thinking. But then F64.1, which is also included here in the definition, is dual role transvestism. Now, again, really old language, but essentially that includes anybody who wears the clothes of the opposite sex for any reason that is not kind of sexual in nature, to enjoy the temporary experience of membership of the opposite sex, but without any desire for more permanent transition. So included in the gender identity disorders diagnosis is this F64.1 dual role transvestism. People like drag queens could be diagnosed under this diagnosis, right? Amazing. Drag queens, drag kings, people who just dress outside of the norm for their gender could be diagnosed under F64.1. Really interesting. Then F64.2 is gender identity disorder of childhood, which is essentially the sort of binary trans experience that manifests during early childhood, characterized by a persistent and intense distress about one's assigned gender, together with a desire to be, or insistence that one is, of the other sex, in inverted commas. Now, what's interesting here is that gender identity disorders in individuals who have reached or who are entering puberty are not classified here. They're instead classified under F66, which is the sexual disorders category, not classified at all under F64. So in here, we do not have anybody who has a gender identity disorder that started in puberty or around puberty. Really, really interesting, given the work that we found that, a lot of people don't come out until puberty. Even if they experienced it in childhood, they don't necessarily tell anyone. And not everybody experiences it in childhood. Lots of people experience it for the first time in puberty, come to their gender knowledge in puberty. But as Professor Greta Bauer showed, people who come to their understanding in puberty are no less valid than people who came to their understanding in childhood. And yet here are not classified under F64 at all and wouldn't be considered, just wouldn't be considered as part of the community that's being assessed in this research. So fascinating. So F64 also includes other gender identity disorders and gender identity disorder unspecified. But it's fascinating, right? And it also doesn't obviously include, so it doesn't include people who came to their gender knowledge in puberty. It doesn't include non-binary folk because they're not captured under the transsexualism heading. It doesn't include gender diverse folk who are non-binary. So not just non-binary communities, but also like demi-boys and demi-girls whose gender identity isn't strictly binarized, but aren't necessarily in the non-binary community. They fall along the spectrum in a different place, but are still in that kind of gender diverse space that isn't necessarily strictly binary. They don't get captured here either. So, and what does get captured here are people whose gender presentation is outside of the norm, right? So, anybody who is a drag king or drag queen or whose gender presentation just falls outside of the norm, who has sought help for that from medical services, would get captured under the kind of gender identity disorder banner. Super interesting. Now, the researchers also took a look at F66, which is the psychological and behavioral disorders associated with sexual development and orientation. So people who experience uncertainty about their gender identity or sexual orientation, which cause anxiety or depression, get captured under here, as do people who just wish they had a different sexual orientation, or people who have difficulties forming or maintaining relationships with sexual partners, all get captured under F66. Less relevant here, but still important because these authors do take a look at F66 separately. Most importantly, what is captured in F66 is people who come to their gender knowledge, who might be gender diverse, but come to that gender knowledge in adolescence, will get captured under 66, not F64, as far as I can tell. So these authors took a look at all the people aged 5 to 24 from 14 million records. And they took a look at essentially the billing data reported quarterly from 2013 to 2022. And they looked at the persistence of diagnosis from 2017 to 2022. They wanted to know if people were diagnosed with F64 were diagnosed with gender identity disorders in 2017, how many still had that diagnosis in 2022? Now that is interesting, right? Like not self-report, just people seeking medical services. Are they still seeking medical services in 2022? But we have to bear in mind that they must be receiving billable healthcare for their gender in order to be considered as still, in inverted commas, persisting. And they must be receiving healthcare that isn't paid for privately, because they must be receiving healthcare that is billed to the national insurance system, right? So if you have a young person who in 2017 goes to their GP, starts to receive therapeutic input, starts to receive, receives a diagnosis from the GP, it's billed through the ICD-10, through the national insurance system, and they start receiving support, but they switch to a private practitioner because it took too damn long for the national system, for healthcare to reach them. If they switch to private, then private healthcare isn't billed through the same system, so they would not be considered persisting. Also, if they no longer sought medical transition, but still experience themselves to be gender diverse, they also wouldn't be considered as persisting. So this is really important stuff, right? Who we think of as trans in the data set and how we think of them as still persisting as trans is really, really important. They must be receiving healthcare. They must be receiving it from a national healthcare provider who is billing it through the national insurance system. And and they must be continuing to receive that over the 5 years in 2022 in order to continue to be considered as persisting. Bearing in mind also, right, people who successfully transitioned and are no longer receiving active healthcare, right? Either they're receiving their medication through some other system, through private practice, or they're just not, like, they're not continuing to transition. They've already been through the transition related pathway and they're not actively receiving any billable healthcare. Even if they are considering themselves to be trans still, they wouldn't be considered in this data. All right, so listen. We take a look at the method. All right, we take a look at the method. We take a look at the quite nuanced, kind of detailed take of the method. It's important that we do that because we are going to look at the results, and the results are going to surprise us. The results, first of all, don't surprise us. First of all, they say the number of people diagnosed as F64 in inverted commas, people who experience gender identity disorders in inverted commas, increased over the time between 2013 and 2022 pretty dramatically, starting with like very, very small numbers of people diagnosed in the sort of 50 odd range, maybe 100 people diagnosed in 2013, up to, thousands, in the early thousands of people diagnosed in 2022. So that's a lot of people, right? Like, it's a huge increase over that time. And the bias is toward kind of adolescents, and adolescents assigned female at birth tend to be the kind of where the bias is toward adolescents. And that is not uncommon, right? Okay, that's the same across a bunch of studies across the Western world. We're finding this big rise in the number of diagnoses. The authors quite appropriately say, listen, we can't really explain why. Like, the study isn't designed to explain why, or whether it's plateauing. Like, we don't know, right? All we know is that the number is dramatically increasing. The number of F66 diagnoses at the same time is decreasing. So what they found was that the number of F66 diagnoses around sexuality decreased, while the number of F64 diagnoses, gender identity disorder, increased, such that the diagnosis of either F64 or F66 remained pretty much stable across the time period 2013 to 2022, which is interesting. I mean, we can't really understand why that's the case. But I think what we can say is that people who once would have thought of their experiences or been thought of with their experiences as having difficulties with their sexuality are now maybe more appropriately being considered having challenges with their gender identity, essentially differences of gender identity, which I think is interesting. We don't really know why. The other thing that's probably not really interesting, or at least not surprising, still interesting, is that most people with an F64 diagnosis in 2022 had at least one psychiatric diagnosis as well. So people had depressive disorders. About half of the people with an additional psychiatric disorder had a depressive disorder. About a quarter had an anxiety disorder, a quarter to a third. About 10% to 15% had an emotionally unstable personality disorder of the borderline type. Once again, quite old terminology. Attention deficit hyperactivity, so ADHD, in about 10%, 12% of people. And about 10% of people experience PTSD. And overall, people had at least one additional psychiatric diagnosis in about 72.4% of people who also had an F64 diagnosis. Again, not easy for the authors to understand why that might be the case. We can say that people who, we've said this before, that people who are gender diverse are at increased risk of child abuse, are increased risk of bullying and victimization, are at increased risk of being assaulted. And so we're expecting that there's going to be an increased prevalence of psychiatric diagnosis. Also, we've got to bear in mind that people who are diagnosed with an F64 diagnosis may already have been diagnosed with depression or anxiety or some other psychiatric diagnosis before they got to F64 in their understanding, right? So, for example, gender diverse folk often don't easily come to their gender knowledge because they have to mask, because of the risk of to their well-being, right? Their risk to their physical safety. And so they often might present with depressive disorders or anxiety disorders, looking for help, but not necessarily looking for help with what is really going on because they haven't yet understood what is really going on, which is that they are gender diverse potentially. So both of those reasons, I think, might help to explain why there's such a burden, upon people who are gender diverse with additional psychiatric diagnoses in this sample. But the headline finding, the big finding, this is where things get, I think, super interesting. So the longitudinal cohort, 7,885 people. 20 to 24 years of age at the end of the longitudinal period, they found that 5 years after the original diagnosis of F64, that's gender identity disorder very broadly defined, after 5 years, the diagnosis persistence, the people who still were receiving billable healthcare from the national insurance system for gender dysphoria, or rather for gender identity disorder, was below 50%. So for young people assigned female at birth, 15 to 19 years of age, only 27.3% were still receiving billable healthcare for gender dysphoria or gender identity disorder, rather, after 5 years. For 20 to 24-year-old folk assigned male at birth, it was 50%, roughly, were still receiving billable healthcare. But it's far lower than you might expect, right? And that's where they say, in total, in the longitudinal cohort, only 36.4% of people still had a confirmed gender identity disorder diagnosis after 5 years. Now, the authors say this is consistent with the wider literature. Now, I take a little bit of issue with that. I don't think it is consistent. It's consistent with some of the wider literature for sure. Steensma's work, Zucker's work, absolutely. But it's not consistent with Gilgo's, Olson's work. And we're going to take a look at one of those articles in a moment. But the authors say that, the diagnostic persistence over the 5-year follow-up period of less than 50% in all age groups is in line with the wider literature and presumably reflects the fluidity of a concept of gender identity in childhood and adolescence. They draw upon one article to support this point, and that article is a commentary paper which is making the same point, but it's recruiting Steensma's work. Now, it's not good practice to cite a commentary paper to support a point this important, and we're not going to get into Steensma's work. We've talked about it before. It's not the focus of this episode. It does seem to show a kind of, again, relatively low level of, in inverted commas, persistence. So it does kind of support the point, but I do take issue with the idea that it reflects the kind of wider literature. I'm not sure that it is, all the wider literature agrees with that point. But the question for us is, why does it show a less than 50% persistence rate? Now, that's the reason that we went into such a deep dive into the methodology, because the methodology helps us to understand why that might be the case. Now, I think it is reasonable for us to say, it is true to say that this is a pretty big study. It's pretty robust in a number of different ways. And it does show, I think we can say that it does show that people who are young people diagnosed with an F64 diagnosis in 2017, most of those people no longer were receiving national insurance billable healthcare from a national provider that can bill through national insurance 5 years later for gender identity disorders. They were no longer receiving it. Less than half were still receiving it. Now, how do we interpret that is a bit more tricky, because on the face of it, that's a low rate. But there's a few points to bear in mind that we have now exposed through our sort of critique of the methodology. So first, there are no diagnostics or services for gender diverse folk who don't fit neatly within the gender binary, right? So do those folk get an F64 diagnosis and then find their way into some kind of healthcare? Do they get an F66 diagnosis and find their way into healthcare? Do they get no healthcare at all? Do they get in through the front door at time 1 and then are unable to continue receiving the healthcare that they want because they don't fit into the binary upon which the healthcare system is built? That's not uncommon, right? So you go to your GP, you go to your healthcare provider, you get diagnosed with a gender identity disorder, you seek transition-related healthcare, and they won't provide it because you don't fit within the gender binary in some way, right? They don't provide it in the same way, and then you fall out of the system because you can't get access to it through the national health system, and so instead you go private, or you don't go at all, and you don't receive transition-related healthcare. Or, it also is problematic for people who do get diagnosed at the beginning, start to receive therapeutic services, and then decide they don't want medical transition 5 years later, right? Don't seek medical transition 5 years later. It doesn't mean that their identities are no longer gender diverse, and it doesn't mean their identities are no longer valid. It just means they're no longer receiving transition-related healthcare. And we know that a number of people, like, Herman's study, other studies in the field demonstrate that, including in Germany, it's not necessarily the vast majority of people who receive transition-related healthcare. So just in Herman's study alone, Herman and colleagues, 2023, they found that when we're talking about the binary adolescents, gender diverse binary adolescents, so essentially binary transgender adolescents, we find that 95% of those do have transition-related medical treatment wishes. But when we're talking about non-binary adolescents, only 62% were seeking gender-affirming hormones and/or surgeries. So people who are non-binary who are diagnosed at time 1, who don't seek transition-related healthcare at time 2, won't be included here. And those that want it and can't get it also won't be included here, right? But even we're talking about the binary trans sample in Herman's study, only, we still had 5% of that sample who ultimately didn't seek transition-related healthcare. So even if they were diagnosed at time 1 and started to receive therapeutic intervention or started to receive any kind of intervention at time 1 and then didn't go on to seek transition-related healthcare, those folks are not going to be included in the sample either at time 2. Now, more importantly, I think the wait lists for public sector services, particularly for gender diverse communities, are prohibitive. I tried to find out in Germany what the wait list to start hormone therapy was, if desired, and it's 6 to 24 months. And a real life experience of 1 year is, I think, required, as far as I can tell, prior to transition. So the wait list, 6 to 24 months, is obviously very long, and for some people might be prohibitive. And for some people who might decide to go private, those people then would not be considered in the follow-up statistics. And people who found the real-life experience prohibitive. So for those who don't know, the real-life experience is where doctors, happened to me, where I went to go and see my healthcare provider, went to go to the gender identity clinic, and they said, we need you to essentially transition socially in all areas of your life, be a woman in the world in all areas of your life, whatever that means. And you have to do that for a full year before you can receive any kind of therapeutic intervention, and particularly any kind of hormones, right? And I was like, but how do I pass in any way? How do I use the bathroom? How do I go to the loo? How do I fit into society? How do I go to the gym or, without hormones? You want me to do that for a full year? And they were like, yeah, we need to make sure that you're sure, essentially. And so the discrimination, the stigma, the prejudice that come from that year of having to socially transition without any kind of hormonal support would, I imagine, put some people off further transition-related healthcare. So some people might push people into the private sector again. So again, people who get diagnosed at time 1, who then face the real-life experience, who then face the waitlist, may not show up in the healthcare stats at time 2. In Germany, psychological assessment and intervention are also very often required prior to transition. So often the case all over the place in Europe. And again, psychological assessment and intervention particularly if you're experiencing comorbid difficulties or particularly if you're experiencing neurodiversity, you might well experience those things to be prohibitive in some way, and therefore kind of either completely bounce off the waiting list or seek private healthcare. And of course, controlled eating and exercise behaviors, bullying and victimization, neurodivergence, poor access to healthcare are all likely quite significant barriers to treatment, a double disadvantage for people at those intersections, pushing people to mask, inviting people to fall out of the healthcare system. So while we have a kind of low persistence rate here, there might be some other reasons, right? Not only that, of course, but we've also included people who have dual role transvestism, right, in inverted commas, in the stats. So people who sought help for their gender identity disorder, in inverted commas, at time one, but just ended up wanting to dress differently to the norm, will still have received that F64 diagnosis at time one and will have bounced off of healthcare systems because they might have realized that they're just like perfectly wonderful, diverse people who enjoy dressing in different ways to those expected by the sort of gendered cultures in which we live, right? And those people wouldn't have been counted at time two. So the definition of trans is obviously really weird, right? Here, the definition of what we consider to be gender identity disorders includes people who dress outside of the norm, excludes people who are not binary, excludes non-binary communities, which is like 10% of the trans population, and excludes people who experienced their gender like knowledge, who came to the realization they might be trans in adolescence. They get diagnosed as F66, not F64. So, lots of difficulties with who gets defined as having a gender identity disorder in this research. And that's going to come in handy because a very, very different study was just published by Christina Olsen and colleagues. Again, looking longitudinally, and again, looking at the persistence rate, in inverted commas, how frequently people who identify as transgender continue to experience themselves to be transgender many years later. So Olsen and colleagues, Christina Olsen, Raber and Gallagher, just literally published 2 days ago in JAMA Pediatrics, Levels of Satisfaction and Regret with Gender Affirming Medical Care in Adolescents, looking at exactly the same topic. So Christine Olsen is a professor at Princeton University. She's very well published. I mean, you know this by now. If you've been listening to the podcast, you know I'm a huge fan of Christine Olsen's work. Very prolifically published in the field of gender identity specifically. My apologies, I couldn't find a huge amount of information about J.F. Raber, but Natalie Gallagher is a data scientist at Princeton University. So it's really, it's a good team. Like Christine Olsen alone as the lead author here has the scientific chops, I think. Hugely published author. Actually, how many articles has Christine Olsen published? Christine Olsen has published 122 pieces of work, and they've been cited well over 7,500 times. She's impressive in a kind of slightly frightening way. Okay, listen, I really am going to pass out if I ever meet her. Amazing work, like an amazing author, and it's not going to be surprising that JAMA Pediatrics is such a big journal for those who don't know. And I will say that while I thought it was a big journal, I didn't know how big it was. It's a monthly peer-reviewed journal published by the American Medical Association. It has an impact factor, bearing in mind that, like, if I publish in an impact factor of 4 to 5, it's a good day at the office for me. Listen, it's a real good day at the office. That's great. I feel really happy if I ever publish in a journal like that. The impact factor of the journal in which Olsen published is 26.1. 26 is bigger than I've ever seen. It's one of the biggest, one of the top pediatric journals in the world, JAMA Pediatrics. So this author and this journal are terrifying, incredibly impressive, amazing. Now, again, looking at the background here, they are looking at puberty blockers and gender-affirming hormones before youth reach the age of majority. So most people transition in adulthood, right? But some people transition in childhood and adolescence, bearing in mind that puberty blockers and gender-affirming hormones are only really available to people in adolescence. Puberty blockers tend to come first, and then gender-affirming hormones come later. People who have problems with puberty blockers and are concerned about health outcomes often don't bear in mind that people do take gender-affirming hormones afterwards. So puberty blockers don't permanently prevent puberty. You don't just go through life never having puberty. You then often take gender-affirming hormones, or you stop taking puberty blockers and then you go through puberty. So while people are like, oh, puberty blockers, might cause some problems for developing brains and bones, for sure, until you go through puberty. Important to bear that in mind. Before the age of majority, so they were really interested in in the challenges that are being posed to the community, where while there are low rates of stopping puberty blockers and gender-affirming hormones, as we found in the CAS review, indeed, their review of UK healthcare demonstrated that people very rarely stop puberty blockers and very frequently go from puberty blockers to gender-affirming hormones. Of course, Olson points out quite appropriately that this does not mean low rates of dissatisfaction. People might be on a pathway they can't escape, or they might feel like they've got a sunk cost bias. They've gone into, they've put so much into it, going through puberty blockers, that they feel they have to go throughout the other end. It doesn't necessarily mean that they are satisfied with their transition. And indeed, some individuals do go on to regret their transition. We know that is coming forward. We know that regret does happen. It doesn't happen very frequently, it seems, but it does happen. And so we need a good, big, prospective longitudinal study to work out, do individuals regret en masse? What is the rate of regret and rate of satisfaction that people experience from puberty blockers and gender-affirming hormones from the age of 12 years or older? Because apart from anything else, people under the age of 12 might have difficulty with the very long surveys that Christine Olson is going to give them, but also because puberty blockers are rarely prescribed below the age of 12, right? Because there's no point in taking puberty blockers until puberty's beginning. So aim and design then. So this piece of work from Christine Olson, really interesting, Trans Youth Project. They're collecting longitudinal data from 317 youth currently, all who joined the project from the ages of 3 to 12 and who had all socially transitioned at the start of the project, which is interesting. We are going to come back to this. But it is interesting that these kids knew at quite young ages that they were trans, right? Very frequently, very young, first knowledge of transition, first knowledge of their gender. First gender knowledge happened quite young, which is really interesting and important to bear in mind. Before joining the study, only 12% had begun gender-affirming healthcare. So they brought in people around the age of 12 to the beginning of the study, 12 and up, most of whom had not received any kind of gender-affirming healthcare prior, and most of whom, all of whom had socially transitioned, and they gave them surveys. They basically gave them these absolutely stonking great hour-long surveys to all of the young people, and they asked their parents to complete the surveys as well, so that where the young people, they're adolescent, where they didn't complete the survey because they didn't have time, if they got their parents to complete it, then at least they have some data from parents about satisfaction and regret. So they got 220 young people accessing hormones and or blockers. 163 of them then completed their own surveys, and 57 parents completed surveys on their behalf, essentially. Parent surveys, equivalent surveys, but, completed it on their behalf. Now, importantly, there are a bunch of kids who didn't complete the survey, right? That's important, right? The second survey, they didn't complete it, or the first survey, I don't think they can't be included because they didn't have either the first survey or the second survey or either. And those kids are like in the 40s, like 48 or something. It's quite a lot of kids who didn't complete the survey. And of those kids, 34 of them have no, like the authors didn't have any kind of survey data from them at all. A bunch of the kids they did from previous years, but they didn't have them from this year that they were doing the study in. So they couldn't include them in the proper analysis, but they do have some sense of their satisfaction. But for 34 of them, they really don't have any sense of their satisfaction, but they do know whether or not they continued healthcare, which is super important. So we're going to keep that in mind too. Assessment of regret. So they looked at satisfaction and regret, and they basically asked, how satisfied are you? How happy are you with your transition? And they gave them a 7-point scale from not at all happy to extremely happy. And they considered anything from 1 to 3 in the lower end of the scale to be dissatisfied with their transition. Their hormone blockers and or cross-sex hormones. And they asked about regret. So 1 was no regret, 7 was strong regret, and anything between 5 and 7 was considered regretful. But they treated the data as both continuous. So they entered the data as a full 7-point scale, and they entered it in as binary. Yes, regret, no regret. 5 to 7 considered regret, 1 to 4 considered no regret. And they found no difference. So treating the variables as consistent or binary produced the same result, which is important, right? How they define regret, how they define satisfaction is important. And they also asked people, they said, listen, would you wish you had received it earlier? Did it come at the right time? Do you wish you'd received it later? Or do you wish you'd never received it at all? And of course, if they wish they'd never received it at all, they considered that regret. But still interesting data regardless. So that's interesting. And they conduct the analysis using R, which is basically a statistical programming language, which is kind of, top tier. I can't use R. Like, I'm bad at it. I'm waiting for AI to be able to use R on my behalf. This is terrible, terrible science. This is really good science. Using R, using the plugins Tidyverse, Lubridate, RStatics, Knitter, and Cable Extra are all ways to be able to use R in specific ways. But as far as I can tell, it's pretty high level stats. So 68 boys in the sample, 132 girls. Boys as in they are young people who identify as boys, I think. 132 girls, young people who identify as girls. And 20 gender diverse or non-binary young people. So they did include non-binary participants and gender diverse participants who were sort of sat outside of the binary. Really important. And they looked at dissatisfaction. They looked at regret after 5 years of receiving puberty blockers and or gender affirming hormones. I know I referred to it as cross-sex hormones a minute ago. Apologies for that. Gender affirming hormones. So how many of these people, hundreds of people, experienced dissatisfaction and regret? Of young people on puberty blockers, dissatisfaction was reported by 5 of them. 160 youths on puberty blockers, dissatisfaction was only reported by 5. Of the 55 parents, dissatisfaction was reported by 3. Regret with blockers was reported by 9 out of 159 youths and 3 of 55 parents. Dissatisfaction with hormones was reported by 4 out of the 119 youths who were taking them and none of the parents. Regret of taking hormones was reported by 5 of 119 youths who were taking hormones. And again, no parents. So the vast, vast, vast minority of people were experiencing dissatisfaction or regret with puberty blockers or with cross-sex hormones, gender-affirming hormones. Again, the vast majority of people, 149 of 158, reported that blockers came at the right time or wished they'd started them earlier. That's 51 of 54 parents as well. And 112 of 117 youths said they wanted hormones they got them at the right time or wanted them sooner. And all of the parents said the same thing. and 214 of 220 youths in total continued care through the study's endpoint. So the vast majority of young people, it's 214 of the 220 youths in the study, all continued care through the study's endpoint 5 years later. Now, the secondary sample, the people for whom we have missing data, basically 49 young people who didn't complete the measures, who were like, they could have done, they met all the criteria, but they didn't complete the measures. Of the 49 who didn't complete the measures, 46 of them were continuing care, and 11 reported satisfaction in earlier annual surveys. So while there remains now 34 of these young people that we don't have accounted for in the data, because they didn't complete the survey and didn't complete earlier annual surveys, the vast majority of those still received medical health care from this service in the States. So this is pretty huge, right? We have a group of young people here, quite a diverse sample. We have a group of young people around the age of 13 when they first started hormones, around the age of 11 when they first started blockers. 30 of them were considered themselves multiracial non-Hispanic, 18 were white Hispanic, 155 were white non-Hispanic, and 17 were other racial or ethnic background. 79 of them were assigned female at birth, 141 were assigned male at birth. It's a wild sample, and only 4% of participants reported regret in the main sample, and only 2% stopped all gender-affirming healthcare. So the regret rate here was extremely low, and the vast majority of people continued to receive healthcare after the 5 years. So why? Why in the world is this the case? Why do we have two different studies showing such radically different rates of, in inverted commas, persistence, or such different rates of continuing to receive healthcare? The sample, I think, is the key. Because here, these children recognized their transgender identity by roughly 4 years of age, mostly. Socially transitioned on average age 6.7, and most were fairly binary in their identities. Only 20 were kind of non-binary or gender diverse outside of the binary system, right? So these kids are not representative of the kids in the other sample from the other study. The other study was a massive national sample of billable transgender healthcare, looking at old definitions of gender identity disorder, very broadly defined, including people who dressed unusually, who didn't experience themselves to be transgender, and that excluded non-binary folk, and that often came to their gender knowledge later. Whereas this sample is one that come to their gender knowledge almost exclusively in early childhood, who socially transitioned quite early at the age of 6, and most were fairly binary, but included people who were non-binary in the sample, right? And importantly, this sample had lots of parental support, and maybe in part as a consequence had normative mental health generally, which is very much not the case in the German sample, right? They had access to responsive medical care. They had a higher income generally. So this sample is quite a discrete sample in that it maybe doesn't represent the German sample that we looked at. So how do we rationalize this? I suppose the first thing we have to say is who is transgender in these studies, who is considered transgender, makes a huge difference in thinking about whether, the rate of persistence and the rate of persisting in medical care and how gender identity remains stable over time or fluctuates, right? And the big point is that when we're talking about Christine Olsen's study, we're saying that people are, these folk know very young, they are insistent, consistent, and persistent, and they know from quite a young age, and they are transitioning in quite significant social ways at quite an early age. Whereas if you're looking at a much broader community sample, and especially if you're looking at gender identity disorder so broadly defined that includes people who are dressing outside of the gender norms, then those people are not always transgender, right? Those people, their identities might range and change over time, but here's what's really important. The persistence in the medical system does not make you more valid or less valid, right? Identities that are more fluid, that change, which might be captured in the German sample, right? People who come to their gender knowledge a little later, or whose gender identities are naturally more fluid or change over time, or whose gender identities change over that 5-year period specifically, they're no less valid, right? And just because they have a different identity at the end of the sample, if they do have a different sort of gender identity at the end to at this beginning of a longitudinal survey, it doesn't mean that their identity at the beginning was at all invalid. Also, people who no longer seek medical care are not necessarily people who are no longer gender diverse, and people who no longer seek medical care from the national system who go private doesn't mean they're no longer gender diverse, and it doesn't mean that their identities are any less valid. I think what we can say here from these two very different studies is that people who know very young, who have a stronger gender identity, and who are compelled to socially transition younger because they are experiencing such deep and profound incongruence between their gender identity and the way in which the world is relating to them, they seem to need medical healthcare, like transition-related healthcare. They need that healthcare more consistently. And in the wider community sample, when we're looking at gender diversity more broadly, we can see that gender is actually extremely broad, and that people can find themselves in multiple different places on the gender spectrum, that they can be more fluid, that their gender experience can change over time, but that doesn't make them less valid. And that there is a problem potentially in the medical healthcare system, which is quite binarized, that is talking about, looking for people who are binary transgender, who experience insistence, consistence, and persistence over time, and that healthcare systems aren't really set up to support people whose gender identities are more fluid or that change over time, or that find themselves in less common, less binary places on the gender spectrum. So let's write back to our young person, shall we? I'm going to write back to our young person who sent us the question. And this can also go to our question asker too. Let's make some points about this article. Dear question asker, thanks so very much for writing to us. Thanks so much for listening to the podcast as well. Hey, you are very welcome here. The German article does seem to suggest that most people diagnosed and treated medically for gender identity disorder within the German medical system do not continue to seek medical intervention 5 years later from that same system. This research matches other research in the field where gender diversity is so broadly defined. Here, the definition includes people who dress differently to cultural gendered expectations, so it has a pretty broad definition. Additionally, and almost paradoxically, the diagnostic criteria also excludes anyone who is gender diverse, but who is not seeking medical transition, and also excludes anyone who does not sit comfortably within the gender binary. The upshot is that people who early in their journey anticipate wanting medical transition and receive a diagnosis, but who later continue to be gender diverse but don't seek medical transition from the public healthcare system, are counted here as not persisting. People who start in the public healthcare system and find it prohibitive, switching to private healthcare for transition-related healthcare would also be counted here as not persisting. What we can say with confidence is that most children and young people diagnosed within the German public healthcare system are no longer receiving transition-related healthcare from that system 5 years later. The authors describe this as akin to a lack of persistence, implying that these young people are no longer gender diverse, and I think that neither this study nor its cited studies can support that claim. I'd recommend taking a look at this article from Olsen and colleagues. This is a more nuanced approach to the question of gender diversity, and is one of the most interesting longitudinal studies I've seen recently, pondering the question of how children's gender identities evolve over time after they socially transition. This article shows that young people who know from a young age, who have a stronger gender identification, they need medical healthcare systems and use those systems more consistently over time. But it doesn't mean that their identities are any more or any less valid than anyone else's. Only a person can know what gender they are, and they have to look inwards, nowhere else. What we can say is that our healthcare systems tend to privilege binary trans experiences and tend to marginalize those experiences that are in rarer places on the gender spectrum, despite our understanding that those experiences are equally valid. And from Herman's study, we find that at least 10% of the population of trans people experience themselves completely outside of binary definitions of gender. People who are non-binary arguably need healthcare in the same way as any binary trans person. Their destination might be different, but it doesn't mean that they don't need that healthcare, and they don't need it to be responsive to their needs in exactly the same way. Overall, though, the question of persistence distracts us from the question of validity. It implies inherently that because somebody is persistent in their identity over time, that identity is somehow more valid. And I think that's a problematic way to think about gender identity. Gender identities are flexible. They change for lots of people over time, and for some people, their gender identities are inherently fluid, more fluid than others. And that doesn't make them any less valid than people who, like myself, are perhaps a touch more binary in our identification. Ultimately, though, the gender diverse communities out here would all nod along with your description. It's such a familiar experience. There is a concept within the community called found family, an idea born of a need we all have to belong and the challenges we so often experience belonging anywhere. But found family is also a phrase we use to reassure our gender diverse kin that you are not alone. Find those who understand you. Surround yourself with the people who love you, and know that as a community, we're going to work together to make a world where we can all find a place to belong. Wow, we don't usually do such a deep dive into articles like this, do we? It's obviously is a bit of an in-depth episode, lots of deep science, but I hope you found it interesting. I hope you found it interesting to know how we critique literature. Hey, if you want to support the podcast, please do share it with someone you love. Go email someone right now. Go say, hey, I like this podcast. I think you'd like it too. Because this is Classroom Psychology, and you are exceptionally welcome here. And our community can only benefit from growing. And I look forward to seeing you all, as always, in the next one.